Hello everyone, Dr. Akshaykumar Kamble here, consultant neuroradiologist. I'll be taking another mock exam today. So this is going to be viva on Teams, which will be online. I think that's pertinent because has also moved after COVID online. And when I was talking with my registrars, they had some of them had tough time and anxiety about doing it online because you don't able to pick up cues from examiners and things like that. Sometimes things doesn't scroll, things doesn't get load up. So we are hoping to kind of use that same experience here and try to make you guys feel at home and peace. Thank you, and I hope you'll enjoy it. Yeah.
Sure. Thank you. Thank
So,
you.
patient presenting with headache. Yeah.
Okay.
I'm scrolling from below to up.
So I'm given the plain CT print of this adult patient who presented with a headache. I can see there's a heterogeneous mass lesion over, I'm thinking the center over the corpus callosum. And ideally, I would like to have a coronal view to better delineate the exact location, but I think in this view, probably in the corpus callosum. And this is still a non-contrast. Okay. This mass lesion exert significant mass effect on the bilateral lateral ventricles, and for a mass lesion crossing the corpus callosum, my differential list would include a glioblastoma, lymphoma, and in my usual practice, I would inform the referring clinicians for these findings and refer these patients for MRI study.
Okay.
For further delineations. For other complications, I will look for any herniation of the any brain herniations. But in the sagittal view, at least there is no ankle herniation that can be seen.
So, what would you like to do next?
Inform the referring clinical team and suggest for MRI brain with contrast to better delineate the nature of this mass lesion, which could represent a malignancy, and requires a multidisciplinary team meeting with a neurosurgical team afterwards.
Okay. So we'll go to the next case. So this patient presenting with cough.
So I'm given chest X-ray of this skeletally mature patient who presented with a cough. So I noticed there is a mass lesion in the left mid zone having a acute angle with the mediastinums. So this is likely in the pulmonary in origin, I think. And there is an elevation of the left hemidiaphragm, and suggestive of, and there's a reduction in lung volume of the left hemithorax. Wait a second. So for a mass lesion with a reduction in the left lung volume, I'm thinking about the underlying lobar collapse. Though I didn't see, I can still see the left hemidiaphragm. In my usual practice, I would like to see if this patient has a lateral chest X-ray for better delineation in the location of this mass lesion. and I would like to inform the referring team and refer these patients for a contrast CT thorax for further assessment of for further delineation of the mass lesions. Otherwise, the rest of the chest X-ray, apart from the mild left pleural effusion, there's no right pleural effusion or no pneumothorax.
So, would you like to summarize your findings?
This chest X-ray shows left mid-zone mass with acute left mid-zone mass with a reduction in the left lung volume, and as evidenced by the elevation of the left hemidiaphragm. And this raises suspicions of underlying malignancy, and would like to refer these patients for contrast CT thorax for further assessment.
What else can cause the left hemidiaphragm to be elevated? Usually, which diaphragm is elevated?
I would like to know if this patient has a prior surgical history, which could, because a lobectomy could also give rise to a reduction in the left lung volumes.
Which hemidiaphragm is usually up and which is down? Which is elevated usually in the normal people?
Normal people should be the right hemidiaphragm higher than the left hemidiaphragm. But in this patient, it's a reverse. Apparently, there's a elevation of the left hemidiaphragm.
Yes. So you said that it could be because of the volume loss. What else can cause the hemidiaphragm to be elevated?
Thinking about the involvement of the malignancy involving the phrenic nerve, causing the elevation of the left hemidiaphragm.
So could you correlate with this finding?
Yes. So there is a mass projected over the left mid-zone, probably involving the aorto pulmonary window, with a suspected involvement of the left phrenic nerve, causing the left phrenic nerve palsy, as evidenced by the elevation of the left hemidiaphragm.
Okay. Can you see the screen now?
Yes. So this is a contrast CT thorax, and
yeah, I will scroll it for you. Going below to up, yeah.
Definition. There's a chest drain. Okay. So this contrast CT thorax shows a reduction of the left lung volume. In this soft tissue view, a reduction of lung volume, some left pleural effusions, and also a left chest drain, probably in situ, but I would like to trace the whole thing and also look at the lung window as well.
Yeah. Showing you the lung window. That's the lung window.
Mass lesion.
Yeah. So the most of the lesion is here. So where I'm just keeping still. Yeah.
This is in the. The mass lesion is located in the aortopulmonary window, and likely correlate with involvement, likely involving the left phrenic nerve, with causing the phrenic nerve palsy as correlating with the previous chest X-ray, and there's no other growth enhancing mass in the rest of the film, including the previously seen the liver and also partly included adrenal glands. And I'll also scan through the contralateral lung fields for other mass lesion as well.
That's adrenal gland. Do you want to comment whether that's
left side adrenal?
This is on the.
There is a nodule. I think there's a.
Yeah, there is
nodular thickening over the left adrenal gland.
Yes.
Okay, so this could raise the suspicion of left adrenal metastasis. And the biliary duct is also dilated. For the rest of the films, I also like to look at the mediastinal lymph nodes, which could affect the staging of this malignancy. There's only some short T lymph nodes, but this one is slightly prominent. So, in summary, these patients have a left iliopulmonary window mass with a probable invasion of left friend enough causing friend enough palsy, as well as some prominent mediastinal lymph node, as well as suspected left adrenal metastasis. I would like to inform the referring clinicians and refer these patients for MDT meeting with oncology and also the oncology team or the local regional cancer center for a multidisciplinary team meeting. Since this patient likely is a patient from metastatic, already is having a metastasis. Okay. And yes.
Sharing. So feedback time. So you did good. So when you are given cross section, you are more confident. That's what I felt compared to the radiographs. When you're describing radiographs, once you have found prominent finding, you need to also describe the negative findings about it. For example, if there is any destruction of the surrounding ribs you are seeing, whether anything else going on, whether there is a pleural effusion surrounding. You rightly commented on the lung volume loss, but then you also need to think about whether I'm not finding any surgical lips or anything like that. And phrenic nerve palsy is more likely than because usually if there is a mass, it should actually make the volume more on that side unless there is operation. Yeah. So so you need to think about that. And also so you did well about that case. The previous case, you hit it out of the park. It was midline lesion crossing the midline. You could also have mentioned there was a central necrosis and things like that within it. But otherwise, well done. Good job.
Thank you. Thank you.
Keep it up. Yeah.